اوكي، بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. I'm Dr. Ahmed Makin. I'm from Sudan, and with my colleague Dr. Khalid Dahmani, we are very much honored to have been asked to chair this session. Indeed, we are very proud of being part of this landmark activity in the field or in the history of endocrinology and thyroidology in the Middle East. But thanks to the organizers, and I'm sure the audience will get great benefit from this activity. Thanks to all. And I'm also honored, more honored to be allowed to introduce my friend, Dr. Ali Zahrani, who's going to present the first speech. Dr. Ali is a consultant endocrinologist at King Faisal Specialist Hospital and Research Center in Riyadh. He's a professor of medicine at Al Faisal University, Riyadh. And I'm sure there is a lot to be said about Ali, but Ali is being very modest. Ali is a close friend of mine. We worked together before since the 1990s. And 2000, Ali has been well into thyroidology. He's a man of great devotion to research and clinical practice. Ali is going to talk to us about molecular genetics of thyroid cancer, its translational impact on patients' management. Ali, if you are around, please, the floor is yours. Thank you.
Thank you so much for the opportunity to talk to you today about molecular genetics of thyroid cancer. I would like to thank the organizing committee and the Arab Thyroid Association for inviting me to participate in this wonderful conference. My name is Ali Zahrani. I'm an endocrinologist at King Faisal Specialist Hospital and Research Center in Riyadh. So I have nothing to disclose, and what I'm going to cover in the short time of 20 minutes is the key genetic alteration in differentiated thyroid cancer, briefly actually. And then we will see how those genetic alterations have affected our practice, both from a diagnostic, prognostic, and therapeutic point of view. So to start with, it's important to remind ourselves that these two pathways, the MAP kinase pathway on the left side and the PI3K-AKT pathway on the right side, are very instrumental and fundamental in the pathogenesis of thyroid cancer and many other cancers. As you can see on this cartoon, this is the cell membrane. There are several receptor tyrosine kinases. An example is RET oncogene, growth factor receptors, VEGF receptor, and many others. They actually get stimulated by different stimuli, different signals, transmit this signal across the cell membrane to one of those pathways and frequently to many of those, even other pathways. Again, on the left side, the MAP kinase is RAS, BRAF, MEK, ERK, and then on the nucleus stimulating certain transcription factor and certain genes. And the same thing happens on the right side. Now, the importance of this, that mutations in different mediators like RAS or BRAF or PI3K, when there are mutations, they drive this pathway constitutively without even the need for the extracellular signals. And this is the basis of many of those molecules causing actually proliferation and tumor formation. Now, this is a summary actually of the known genetic alteration, or some of the known genetic alteration. There are actually many, maybe in hundreds of genetic alteration, but these are the main ones. So you can see on the left side here the number of genes or fusion genes and their prevalence or average prevalence in different types of thyroid cancer: papillary, follicular, poorly differentiated, and anaplastic thyroid carcinoma. So as you can see, the papillary thyroid carcinoma, the main player is BRAF V600E mutation, and also the fusion protein RET-PTC, whether it's RET-PTC1 or 3. But rarely you have RAS mutation, you have other types of mutations, including TERT promoter mutation, which is very important. In follicular thyroid cancer, you don't see BRAF and RET-PTC, but RAS mutations are the predominant player, and sometimes BAX8, PPR gamma, and P53, and again, TERT promoter mutation. Poorly differentiated thyroid cancer, you can see some BRAF, some RET-PTC, but again, RAS and B53 and RET are the main players. And the same thing for ATC. You can see some BRAF mutations, but the main players are actually RAS and B53, beta-catenin, and TERT promoter mutations. This understanding came from several studies. One of them is this study called coming from tumor or cancer genome atlas, looking at around 500 cases of well-differentiated papillary thyroid cancer. And again, if you look here on the right side, you can see the list of genes and the frequency of those mutations. So you can see in this cohort of 500 cases of well-differentiated papillary thyroid cancer that BRAF was the main player, occurring in around 60% of the time, NRAS, HRAS, and many others, as you can see here. And down here, you can see some fusion protein, including fusion for BRAF, RET, PBR gamma, NTRK3, and NTRK1, and many others. This is the summary of this, again, slide showing you that BRAF mutation is the main player, RAS and RET rearrangement at much lower frequency, and TERT promoter mutation in well-differentiated papillary is only present in around 9%. B53 is extremely rare. Now, what is the value of understanding the molecular pathogenesis? And again, I have just touched on the basics of molecular pathogens. There are many players in this scheme, but I just mentioned the important ones actually. The value of this is that we have utilized this knowledge into our practice, or whether it is in the diagnostic arena or prognostication or a specific drug development, as I will cover in the next 15 to 17 minutes. So we all know that thyroid nodules are very common. You can see in this old article from Mazapiri in the 90s that up to 50 to 60% of the population, they have actually thyroid nodules on autopsy or ultrasound, and around 7%, 5 to 7%, you can detect it by palpation. So this is a huge burden in the medical practice. We have to know how to deal with it. If you are going to operate on every patient, you're going to operate on at least 50% of the population. And this is why we use fine needle aspiration to send patients who need surgery to surgery, the patients with malignant cytology. Those with benign, which is the majority, can be followed up. But unfortunately, there is always gray zone, and the gray zone comes into the intermediate category, which constitutes around 20 to 25% of cases. Now, the classic practice until around 15 years ago is to send those patients for surgery because we don't want to take any risk. However, the majority of those patients, 70% of them, will turn out to have benign histology. And you would say, if I know this, I would not have sent you for surgery. I would have just followed you up. So 70% of the cases of surgery in this group is unneeded. Only 30% are legitimate surgical intervention. And therefore, the question was or raised at that time, can we use something else apart from fine needle aspiration to decrease the percentage of patients going for clinical, for surgery, and shift more into the clinical follow-up? This work is from Bethesda system that you are all familiar with. And category 1 and 2 are not problem. Category 3 and 4 are problematic because we are really not sure what the histology will show us, what the underlying pathology is exactly. All that you are saying here, this is indeterminate and with different odds of being malignant. Patients with suspicious cytology for malignancy or clearly malignant tumors is not a problem. They will go for surgery. Those with benign cytology can be followed up. Those with non-diagnostic or unsatisfactory can have repetition of the test. But these two categories are problematic. And you can see here the recommendation is to repeat FNA or do molecular testing or do lobectomy surgery. And the same thing for Bethesda 4, molecular testing or sending the patient for diagnostic surgery. This is where molecular diagnostics is playing a part, and we take a sample, we send it for cytology. If his cytology is clear, benign or malignant, we have no problem, but if it is indeterminate, we can take the rest of this sample and do mutational analysis. And if it is positive, we send patients for thyroidectomy. If it's negative, we follow them up. What are the available molecular tests in thyroid nodules? There are several of them, and I will not spend any time on explanation of this table, but to say that the current ones that are in wide use is these two tests. They are third generation tests. We have one called Afirma Genome Sequencing Classifier, and the other one is called ThyroSeq 3 Genome Classifier. So quickly reviewing the data on this, for the Afirma Genome Sequencing Classifier, they used lots of genes, around 10,000 genes. They used gene transcription and mutations, and there are around 12 classifiers, including classifiers for helper cell lesions. And basically, the sensitivity of this test is around 90%, specificity is around 68%, positive predictive value is 96%, and negative predictive value is 96%, and positive predictive value is 47%. So it's a very good test to rule out cancer. If the sensitivity is high and negative predictive value is high, the test is good to rule out cancer. And this is how they send the report, basically. Now, the other test is ThyroSeq. It's similar approach, but using different set of genes and different focus. They focus more on mutation rather than expression. And again, this is the flow chart for how the patients or samples are handled. Again, at the end of the day, you get basically negative or positive. And again, looking at they give you also information about important genes, including BRAF, TERT, BRAF plus TERT, RAS plus TERT, or B53. And again, when you assess the sensitivity and specificity of this test, it is quite sensitive with high negative predictive value. Specificity is not bad, and positive predictive value is not bad. So again, this test is better suited, similar to the Afirma Genome Sequencing Classifier, is better suited to rule out cancer rather than to confirm that it is cancer. However, if it is clearly positive, the chance that the patient has cancer is around 70%. This is basically a meta-analysis that was published last year, and again, without going into all the details, what they found is comparable outcome of ThyroSeq V3 versus Afirma Genome Sequence Classifier. They are not perfect, but they have strong diagnostic testing. ThyroSeq is very good to rule out the disease, followed by Genome Sequencing Classifier. And basically, the two tests are competing with each other, and they are comparable. What about prognostication? The prognostication has been well understood with the discovery of BRAF V600 in the 2003. This is a number of studies that have been analyzed in a meta-analysis, and you can see there is a strong association between BRAF V600 and extrathyroidal invasion. You can look here at the cumulative index. There is strong association with lymph node metastases. There is strong association with the stage of the disease, higher stage of disease stage 3 and 4. And there is an association between BRAF V600 mutation and mortality in patients with papillary thyroid cancer. You can see here BRAF negative, they do very well. BRAF positive, they don't do as well in terms of mortality. And the same thing for recurrence. You can see recurrence is much higher or significantly much higher with BRAF positive tumors compared to BRAF negative tumors. And again, this is a meta-analysis looking at BRAF, showing a strong association with recurrence, with lymph node metastases, with extrathyroidal extension, not really with distant metastasis, but with higher stage of the disease, stage 3 and 4. Now, the other prognostic mutation is TERT promoter mutation, and this is a meta-analysis again for TERT promoter mutation, showing a strong association between the presence of TERT promoter mutation and extrathyroidal extension. You can see again here the summary statistic. Vascular invasion is also strongly associated. Distant metastases, stage 3 and 4, the higher stage of the disease, tumor recurrence, and mortality. So TERT promoter mutation is not a very good mutation, similar to BRAF mutation. And if you combine both of them, the prognosis is really not very good. This study looked at 4 categories of patients: negative BRAF, negative TERT, positive BRAF, negative TERT, positive TERT, negative BRAF, and positive TERT and positive BRAF. And you can see nice flow with very bad prognosis for patients who are BRAF positive and TERT promoter mutation positive, whether for all types of papillary thyroid cancer or for the conventional type of papillary thyroid cancer. The American Thyroid Association did not embrace the data on prognostication in the 2015 guidelines, but they are going to do this in the next guidelines that will come later this year or next year. But you can see that in between the lines, they have pointed out the importance of BRAF mutation and the TERT promoter mutation. So when they are positive, they increase the risk, basically. In the last 5 minutes or so, I will focus on the therapeutic implications. And again, our understanding of the molecular genetics resulted in several drugs that we are using today widely to treat patients with thyroid cancer that is metastatic and progressive. Patients like this who have widely metastatic disease did not have any option around 10 years ago. Today, we have several options for them, as you can see in this cartoon. Thanks to the understanding of molecular pathogenesis of thyroid cancer, you can see the same pathways that I discussed earlier, and you can see several drugs that can block those pathways and decrease the progression of the disease. Again, this is another diagram showing that you can attack the tumor cells at the cell surface or intracellular at these pathways, or even at the immune cell level, or on the surrounding cells like the endothelial cells and mesenchymal cells. So the available drugs for metastatic thyroid cancer include sorafenib and lenvatinib for progressive radioactive iodine refractory differentiated thyroid cancer and poorly differentiated thyroid cancer. And most recently, cabozantinib was added as a second-line therapy when they failed sorafenib and lenvatinib. For medullary thyroid cancer that is progressive and metastatic, we have fenatinib and cabozantinib as a standard treatment. However, recently we have additional drugs that are more specific and they target specific genetic alteration. So if you have RET mutation or RET fusion protein, regardless of the underlying tumor, you can use selpercatinib or ralsatinib. And if you have NTRK fusion protein, you can use larotrectinib or entrectinib. Anaplastic thyroid carcinoma was uniformly fatal. However, in 2018, a study showed that if BRAF is positive, you can treat those patients very effectively with dabrafenib and trametinib. This is the sorafenib data. This is decision trial showing very clear distinction between patients who received sorafenib versus those who received placebo. Very clear reduction in progression-free survival, improvement in progression-free survival for sorafenib group. The same thing for lenvatinib. In the SELECT trial, you can see patients who received lenvatinib did much better than the placebo. And this is a patient of mine who had progressive metastasis in the lungs. This is before lenvatinib. And 4 months later, you can see most of those lesions disappeared. As I mentioned, anaplastic thyroid carcinoma used to be uniformly fatal. However, in 2018, 16 patients were reported who received dabrafenib and trametinib. Dabrafenib is a BRAF inhibitor and trametinib is MEK inhibitor. So this combination resulted in significant improvement. As you can see, essentially each patient showed reduction, either stable disease or partial response. And you can see here a good example of those patients before and after treatment. You can see the tumors shrank significantly and the response is quite durable. Silpercatinib is a new drug that was approved in 2021 actually. And again, this is phase 2 trial showing you patients with RET mutation, medullary thyroid cancer, showing excellent response, whether they were actually exposed previously to fenatinib or cabozantinib, or they are treatment naive. And this is for differentiated thyroid carcinoma who carried RET fusion gene. And again, you can see beautiful response on this waterfall plot. This is one patient that I have, and again, before silpercatinib, she was actually dying. You can see the large tumor she has, and 6 weeks later, you can see most of those tumors shrank significantly or disappeared. The last of this group is the NTRK fusion protein. They are also present in thyroid cancer in around 30% of the time, whether it's adult or pediatrics. And again, those tumors are tumor agnostic, so they have been used for any tumor that have NTRK fusion protein, soft tissue, sarcomas, thyroid, salivary glands. And I will just show you the data on the thyroid cancer. You can see that in this study of 28 patients, which includes 7 with anaplastic, 2 with follicular, and 19 with papillary, there was significant improvement in most of those patients, including patients with anaplastic, and sometimes you get a complete response. So to conclude, and again, I'm sorry for moving fast, but again, I have only 20 minutes to cover this wide subject. Over the last 2 decades, and only 2 decades, in fact, less than 2 decades, progress in our understanding of molecular genetics of thyroid cancer was translated in major diagnostic, prognostic, and therapeutic advances, as I have explained. In the diagnostics, we have the genome sequence classifier, the Afirma one, and the ThyroSeq3 as great tests for thyroid nodules in Bethesda 3 and 4. And they are especially good to rule out malignancy and save the patient from surgery. Prognostically, BRAF V600E and TERT promoter mutations and others, including P53 and beta-catenin, are associated with higher grade thyroid cancer and worse outcome. And I think you will see this more clearly in the next American Thyroid Association guidelines that is coming soon. Therapeutically, as I explained, the field has changed with several drugs in use and many in development, and this field is very active and is likely to continue to improve and bring good news to us as endocrinologists, to the patients. With that, I will stop here. Thank you very much for your attention.
Thank you very much, Dr. Ali. Excellent presentation as usual. We'll now move to the next topic, but just before we move, I just want to remind the audience to type their question in the QA box and also link it with the speaker so that it will be a quick one when you go to the Q&A. So our next session will be thyroid eye disease, and our speaker is Dr. Ahmed Al-Qaisi. He's a consultant endocrinologist at Leeds Teaching Hospitals, and also he is the thyroid lead in these hospitals, Leeds Teaching Hospital. So Dr. Ahmed, please share your presentation and you can proceed.
Hi, my name is Ahmed Al-Qaisi. I'm a consultant endocrinologist in Leeds Teaching Hospital and currently working in St. James's Hospital, which is in Leeds City. Today, my talk is going to be about thyroid eye disease. And in this talk, we will talk about epidemiology, discuss a bit about pathophysiology, signs and symptoms of thyroid eye disease, and we'll talk about the activity and severity scoring system that we use in our practice, the common investigation that we send for, our current treatment, and future emerging treatment. Thyroid eye disease, as you're all aware, is an orbital inflammatory disease that is often associated with a grave disease. However, it is sometimes associated with Hashimoto thyroiditis. And we do have a couple of patients in our clinic where they have some positive antibody, whether TSH receptor or TPO antibody, but they never had any thyroid disease. They also do have thyroid eye disease. As you are all aware, it could lead to a significant impact to the quality of life by its clinical manifestation with proptosis and visual impairment. Grave disease can happen in around 20 to 50 people per 100,000, of which thyroid eye disease could contribute to around 16 in 100,000 in a woman and 3 in 100,000 in men. It's less frequent in men, however, it is more severe. And interestingly, when they took patients with grave disease, some of them do not have signs and symptoms of thyroid eye disease, and they put them in a scanner for their orbit. 70% of them showed some settled changes at the back of their eye in support of thyroid eye disease finding. Let's touch a little bit about the pathophysiology, because that will help us understand the current treatment and the emerging treatment. And to simplify it, just think of the main pathophysiology factor in the thyroid eye disease is the resident orbital fibroblast. The resident orbital fibroblast will attract fibrocyte, T cell and B cell lymphocyte to the area. Now, the T cell, B cell, and fibrocyte will secrete inflammatory cytokines, and also the B cell will secrete IGF-1 receptor antibody that has been recently discovered to have a role in the pathophysiology of thyroid eye disease, together with thyroid stimulating antibody. The TSH receptor antibody with IGF-1 receptor antibody will make, with the B cell and T cell, changes on the resident fibroblast by making it secrete further hyaluronic acid and be differentiated more into fat cells, adipocyte, and myofibroblast that will reach to orbital expansion and lead to the clinical signs and symptoms that we are aware of, which include lid retraction, sometimes associated with ptosis, if there is an association with myasthenia gravis. And the obvious sign, obviously, is proptosis. And because of the cramping at the back of the eye, there will be extraocular muscle dysfunction, which could lead to double vision, together with periorbital edema, corneal ulceration, chemosis, exposure keratitis, color blindness, optic neuropathy, and blindness in advanced cases. The thyroid eye disease starts by active inflammatory phase that could last from from months to years, and a chronic long-term fibrotic phase that could lead to the long-term clinical manifestation, as shown in this slide. The basic of the treatment is to start the our treatment as early as we discover the patient in the active inflammatory phase, because treatment afterward is not going to be as effective as treatment at the beginning of the active inflammatory phase. And you can see by this slide, if we start a treatment earlier, the chronic fibrotic phase could lead to less clinical manifestation on the long term. And less clinical manifestation means there will be less need for emergency decompression or immunosuppressive therapy or corrective surgeries on the long term. So it's not only less clinical manifestation, but it is cost effective on the long term. Risk factor to have thyroid eye disease and even severe thyroid eye disease mainly comes on the top of the list is smoking. And this is not only, this also will include passive smoking. Increasing age, gender, as we mentioned earlier, women will have more frequent disease, while men will have more severe disease. Having had radioactive iodine as a treatment previously, have a high T3 level at time of diagnosis and a high TSH receptor antibody at time of diagnosis. The activity score that we use in our clinic is derived from European group of graves of ophthalmopathy. And these include 7 points for us clinicians that we could record and 3 other points for our ophthalmologists that join us in the clinic that can help us in making the final calculation. Each symptom and sign I will mention will score 1, and these include spontaneous orbital pain, gazed evoked orbital pain, eyelid swelling, eyelid erythema, conjunctival redness, chemosis, inflammation of the caruncle or plica, and further 3 points that will be done by our ophthalmologist with their examination by having increment in the proptosis and decrease in uniocular excursion and decrease of the visual acuity on the Snellen chart. And this is just a reminder to myself how chemosis look like, and a reminder about the position of the lacrimal caruncle and the plica to have a look when they get inflamed. With these signs and symptoms, we could classify thyroid eye disease into mild, moderate to severe, and sight-threatening. And mild, obviously, it will have mild impact on the quality of life, and it does, because of that, it does not justify immunosuppressive or surgical treatment. And we classify patients with mild thyroid eye disease if they have 1 or more of the following: minor lid retraction less than 2 millimeter, mild involvement of the soft tissue, exophthalmos less than 3 millimeter when compared to the age and gender specific, transient or no diplopia, and corneal exposure that is responsive to lubricants. The moderate to severe thyroid eye disease, it is not sight-threatening, however, it will justify treatment with immunosuppression or surgical intervention because it does have sufficient impact on life and it could progress to sight-threatening disease. And it will include 1 or more of the following: lid retraction more than 2 millimeter, moderate or severe soft tissue involvement, exophthalmos more than 3 millimeter compared to the norm for race and gender, and transient or constant diplopia. The sight-threatening thyroid eye disease, obviously from its name, it could lead to optic neuropathy and or corneal breakdown that will warrant immediate intervention. The investigations that we send from our clinic include a thyroid function test, TSH receptor antibody, full blood count or complete blood count, liver function, kidney function test, inflammatory markers, and we consider patient for MRI or CT scan of the orbits. And mainly, this is the imaging technique mainly for differential diagnosis that could include myasthenia gravis, orbital myositis, orbital tumors, carotid cavernous fistula, and inflammatory orbitopathies like sarcoidosis. The treatment for mild thyroid eye disease, we try to achieve euthyroidism biochemically and clinically. We advise for smoking cessation, and we have smoking cessation team that can follow the patient. We also advise for head elevation, artificial tears, lubricant with ointments, oral non-steroidals, mainly ibuprofen, that could improve mild inflammation. And also we may start selenium, that was proven by a study with Marconi and Cahaly group in 2011. It could improve a clinical activity score by 1.3 over 6 months, and hence improve the quality of life. The dose of selenium that we use is 200 microgram once daily. We use it only for 6 months. Other treatment that may be used that I will start to mention, I thought I'll just put them on the pathophysiology slide that we showed earlier, because that will help us understand how these medication work. Now, the most common medication that we use in our clinic is intravenous steroid. We do use oral steroid, but in certain specific cases. Now, glucocorticoid work as an anti-inflammatory medication that will help reduce inflammation in general and reduce production of cytokines. If we have cases for steroid resistant, which could happen mainly in our clinic around every 6 to 9 months, we may use other options like cyclosporin, mainly combined with oral steroid. Cyclosporin work on T cells. Rituximab is our second option, which is a little bit more expensive compared to cyclosporin. It works on B cell depletion. Other treatment that been tried before, especially when IGF-1 receptor antibody been discovered, is somatostatin analog octreotide lanreotide. However, they did not show any major improvement in the thyroid eye disease. Future emerging treatment, which is not licensed yet in UK, include tocilizumab, which is an interleukin-6 inhibitor, and tupratunumab, which is an IGF-1 receptor analog antagonist. The systemic glucocorticoid that we mainly use in our clinic, evident by the Cahaly group in 2005 study, when they took patient and put them on 2 arms, one arm with IV methylprednisolone and the other arm on oral steroids. It is the same dose that we use in our clinic. We use methylprednisolone as 500 milligram per week for 6 weeks, and then 250 milligram per week for another 6 weeks, and this will be a total dose of 4.5 gram. Obviously, in the Cahaly study, it showed superiority of the intravenous methylprednisolone in improving signs, symptoms, and the quality of life. In our clinic, we give 500 milligram for the same day if we think this patient is moderate to severe disease, and then another 500 milligram in the next week. And then we review the patient the week after to see if the patient is responding to steroid or not. And then we will decide whether we should switch to other medication or we should continue on intravenous steroids. Obviously, systemic steroids have side effects. I'm not going to go through them. Other medications that we may go to if systemic steroids are not helping. One we mentioned is rituximab, which is anti-CD20 work on B cell depletion. There were 2 previous major studies in 2007 and 2015. One showed superiority, the other one did not show superiority. However, all these studies were quite limited number of patients. The dose that we use in our clinic is intravenous infusion of 2 doses of 1,000 milligram with 2 weeks apart. For the last 5 to 6 years, we used it for around 6 or 7 patients, and it did show improvement compared to other medications. We worry about side effect of rituximab, hence we give it as in our day unit when the patient is admitted, because it could cause anaphylactic shock and reaction. Other medications that also we could use in our clinic is cyclosporin. Mainly 2 randomized controlled trials have been before. It did not show any superiority to per-oral steroid. However, when you combine it with oral corticosteroid, it did show superiority to oral steroid by its own. There is no randomized controlled trial so far that tested its efficiency against intravenous steroids. Somatostatin analog been tried since the discovery of IGF-1 receptor antibody. 4 randomized controlled trial been done. However, the efficiency of this medication has not been sustained, and the recommendation of this study, it is not generally recommended. Immunotherapy, which we haven't used yet in our clinic, including tocilizumab, which is a useful medication in rheumatoid arthritis. It works on anti-interleukin 6 receptor antibody that will block the receptor. The study that was done in 2018 mainly picked patients who are steroid resistant, and it showed superiority compared to placebo, as you could see on the slide. Other emerging medication, which is with a study published in 2019, teprotumumab. It's a monoclonal IGF-1 receptor antagonist, and it did show quite good improvement, mainly in apoptosis, with improvement more than 2 millimeters in 24 weeks compared to placebo. However, it is a quite expensive medications. Patients who could not have any of these medications, or the medications that are available to us that are failing in achieving good remission for the patient, we may option for orbital radiotherapy, which could be given in our hospital, and these are given in small doses of 15 to 20 gray in 10 sessions. Studies showed that it is equally effective to corticosteroids. However, it can take 4 to 6 weeks to start working, and it does have a short-term side effect and long-term side effect, including dry eyes, cataract, retinopathy, optic neuritis, and secondary malignancy on the long term. Our ophthalmology team that join us in the clinic could offer surgical treatment, mainly for patients who have inactive thyroid eye disease and have a low clinical activity score. And these include orbital decompression, strabismus repair, eyelid repair, and in our clinics, we found that patients with moderate to severe disease, about 80% of them may require rehab surgeries. The sight-threatening TED is around 5% of patients with thyroid eye disease. Major study that was done by Wackel-Kamp showed that intravenous steroid is as effective as surgical decompression. We use more surgical decompression in our clinic, which is obviously guided by our ophthalmology colleague. Patients who would need to have radioactive iodine treatment for their grave disease, when they have some evidence of thyroid eye disease, we do use it. We wouldn't recommend it for active thyroid eye disease, but when we need to use it, we will use it with a glucocorticoid cover, and we may use a dose of 0.5 milligram per kilogram per day up to 2 months post the treatment. Obviously, if patients do not have any contraindication to steroid use. In conclusion, early recognition is very, very important for the thyroid eye disease problem. This will help in improving the outcome on the long term. We do spend time with when new patient has been diagnosed with a grave disease, even if they don't have mild thyroid eye disease, by educating them, giving them leaflets, so that they could let us know if there is any further sign and symptoms happen, so that we can act on it earlier. The emerging therapeutic option is difficult due to some uncertainty surrounding the pathogenesis, but we're quite lucky so far because we do have good evidence for intravenous steroid that works quite well. And thank you very much.
Okay, thank you. Thank you very much, Dr. Ahmed Al-Ghaizi, for a very elaborate and informative account of a very important complication of thyroid eye disease. Thank you very much. The next speaker, or the next guest speaker, is Dr. Carla Moran. She's a consultant endocrinologist at the Bacon Hospital in Dublin and is an associate professor at the University College of Dublin itself, School of Medicine. Dr. Moran has particular interest in thyroidology, having completed a fellowship and PhD in the University of Cambridge. She established a national referral program or service for unusual thyroid disease and provided clinical service for immune checkpoint inhibitor endocrinopathy, which this is a novel therapy she's going to talk to us about. She's also a devoted researcher in the field. In this field, she is an active member of international societies and editorial boards member, specifically the Journal of Endocrinology, or Journal of the Endocrine Society, and is an invited member of the United Kingdom and European Guideline Development Committee for Thyroid Disease. She is going to talk to us about immune checkpoint inhibitor therapy in thyroid dysfunction. Dr. Carla, please, the floor is yours. Thank you very much.
Hello and good afternoon. My name is Carla Moran. I'm an endocrinologist here in Dublin, and I'm really pleased to be able to take part in your Arab Thyroid Association Congress. It's a wonderful honor to take part in such a congress, and I thank you for the invitation. I've been asked to speak about immune checkpoint inhibitor therapy and thyroid dysfunction. And I'm going to share with you my experience of managing these patients, and I hope it will be useful for you. So we'll talk a little bit about immunotherapies and how they work. I'll discuss the type, frequency, and severity of endocrine side effects, how to perform surveillance, how to treat, and how to follow up. I'm sure many of you will have managed patients who have received immune checkpoint inhibitor therapy, and it has really revolutionized the care of cancer patients. And some patients, for instance, with metastatic melanoma who are facing only six months remaining of their life can go into complete radiological remission after having multiple metastases. So these are wonderful medications, but they come with some side effects. And they work really by harnessing our immune system. So I'd like to remind you how T cells are activated. The tumor antigen is presented by an antigen presenting cell or tumor cell by the MHC class of molecules. The tumor antigen is then recognized by the T cell receptor. And this is the initial stimulatory signal for T cell activation. Co-stimulatory signal is required, and that's the interaction between CD28 and B7. And this results in T cell activation. There are natural breaks present in our immune system, and these include the interaction between PD-1 and its ligand, and CTLA4, another protein expressed on the activated T cell, which interacts with the B7 molecule. And together, these interactions result in modulation of the T cell activation and results in reduction of the T cell response. And the knowledge of the presence of these breaks has been used to develop monoclonal antibodies directed against these molecules, which in turn reactivate the T cell. So there are monoclonal antibodies available that are directed against PD-1, against CTLA-4, and against the PD-1 ligand. And these are used for many different types of cancer. They result in immune-related adverse effects, however, and our oncology colleagues are now very familiar with these, and they can affect many different organs in the body, as shown here. They most frequently cause respiratory, skin, gastrointestinal, and rheumatologic side effects, but they can also cause endocrine side effects. And I'll discuss these focusing on thyroid dysfunction in this talk. Oncologists grade adverse effects from their therapies between grade 1 and grade 5. Grade 5 meaning death, grade 1 being quite mild, often asymptomatic. It may just be a laboratory measurement that was abnormal and no treatment or intervention is required. Grade 2 is moderate with minimal symptoms, possibly affecting activities of daily living. And grade 3 is severe with hospitalization. And thankfully, the majority of endocrine adverse effects fall into the grade 1 and grade 2 categories. The PD-1 agents quite frequently cause thyroid dysfunction. And this was a nice review of the literature published a couple of years ago of all published articles that describe thyroid adverse effects following immune checkpoint inhibitor therapy. And you can see that overall, there's an incidence of 10%. The CTLA-4 agents cause thyroid dysfunction in around 5% of patients, but the PD-1 agents cause thyroid dysfunction more frequently, with nivolumab inducing thyroid dysfunction in almost 9% and pembrolizumab in just over 15%. As is the case for many immune-related adverse events following immune checkpoint inhibitor therapy, combination therapy increases the frequency of these side effects. So what type of thyroid dysfunction occurs? Well, we see most commonly primary hypothyroidism. We can see hyperthyroidism, and the majority of that is due to thyroiditis. Very rarely Graves' disease has been described, and even Graves' orbitopathy, but that is indeed very rare. So if you see a patient with thyrotoxicosis following these treatments, you're most likely seeing a patient with thyroiditis. Rarely hypophysitis can occur, and this can be associated, of course, with hypopituitarism and TSH deficiency, so thyroid disease can occur with this. Adrenal insufficiency is very uncommon, but can occur. If we include subclinical thyroid disease, the frequency of thyroid disease is much greater. Patients who develop hyperthyroidism following these agents typically develop it at about 3 to 6 weeks. Most of them will have developed it by 3 months, but smaller numbers will develop it later than that. The median time to development of hypothyroidism is a bit later. On average, it's 6 to 10 weeks. And again, most people will have experienced it by 3 months if they are to experience it. But again, there will be small numbers at later stages who can develop hypothyroidism. This is a typical case of a patient who developed subclinical hyperthyroidism and then went on to develop hypothyroidism. So this man had been treated for melanoma with pembrolizumab, started off with normal thyroid function. You can see his T4 in blue, TSH in green, and these are within the reference ranges. And you can see the T4 starts to rise, TSH becomes suppressed, and he then develops primary hypothyroidism, necessitating thyroxine treatment. So it's a very typical case. There are a number of risk factors that have been shown to be associated with development of thyroid dysfunction following immune checkpoint inhibitor therapy. Melanoma seems to be more commonly associated with this. The type of immune checkpoint inhibitor, as I've shown you, there does not seem to be a sex predilection. And there have been some studies suggesting that perhaps a higher baseline TSH increases the risk. The presence of positive autoantibodies may increase the risk, and perhaps also a higher BMI, but these are not certain. There have been many algorithms proposing methods of screening for thyroid dysfunction following administration of immune checkpoint inhibitor therapy. And I don't think we have to have exhaustive knowledge of all of these, but I do think we need to work with our oncologists to develop an algorithm that will work for the institution in which we are conducting our clinical care. This was an algorithm that was published a few years ago, and I like it because it's quite straightforward to follow, and I think it's a very sensible algorithm. So the authors here suggested that we establish baseline TSH-T4 and that we check TSH-T4 at least monthly for 6 months, every 3 months for the next 6 to 12 months, and every 6 months after this. If the thyroid function becomes abnormal, they have given guidance for how we should be managing such dysfunction. However, I think the guidance they provided is mainly for oncologists. So I think for this audience, I'd like to go into a little bit more detail. So patients who develop overt hypothyroidism, we would start thyroxine, and then you can check their thyroid function test every 4 to 6 weeks to coincide with their treatment cycles. I would always recommend considering checking a cortisol first, especially if they've ever received an anti-CTLA-4 agent, because that's more likely to be associated with hypophysitis. So you may have a patient who also has ACTH deficiencies. It's just worth bearing that in mind. Patients with subclinical hypothyroidism, it would be very reasonable to observe these patients, certainly if their TSH is under 10 and they're asymptomatic. But I would recheck every cycle if you've decided to monitor rather than treat. And perhaps a threshold would be to start thyroxine if they become symptomatic or if their TSH is greater than 10 or rising. Again, I would consider checking cortisol prior to starting thyroxine. For patients with overt thyrotoxicosis, I give them beta blockade. And as I mentioned already, this is likely thyroiditis, so I just observe. Give non-steroidal anti-inflammatories or steroids if it's very painful, but that's very uncommon. Monitor the thyroid function every cycle. If there's persistent thyrotoxicosis, so the reasonable time frame would be greater than 6 weeks, then I'd be thinking, well, perhaps this is a multinodular goiter or Graves' disease, and I would check a TSH receptor antibody. I might consider performing a thyroid technetium scan, but bear in mind that the majority of these patients will have received contrast, and so you may get a negative technetium scan. They may well develop later hypothyroidism, so you need to monitor for that and treat it if necessary. If they were keen to determine whether they needed thyroxine in the long term, I think it would be reasonable to perform a trial of thyroxine at a later stage. Patients with subclinical hyperthyroidism, I'd always make sure that their T3 is within the normal range, because if it's elevated, I'd manage that as T3 toxicosis and essentially manage it as overt thyrotoxicosis at the top of the slide here. Monitor the thyroid function every cycle, and if they became thyrotoxic, I'd manage as above and consider beta blockade. Some questions that frequently arise, is immune checkpoint inhibitor therapy contraindicated in people with pre-existing thyroid disease? And the answer is no, it can certainly be given, but worsening thyroid dysfunction can occur in up to 70% of patients with pre-existing abnormal thyroid function. So these people still require monitoring. Do we need to stop the immune checkpoint inhibitor therapy if thyroid disease develops? And the answer is almost always no. You may consider temporarily stopping the treatment if the side effect is severe. And a useful rule of thumb that I use is that if they're admitted to control their symptoms, then I would temporarily halt it. If there was severe orbitopathy, certainly if it was site-threatening, I would stop the treatment. And then you would have to liaise, of course, with your ophthalmology, oncology colleagues to weigh up the risks and benefits of continuing treatment. I just want to specifically mention about CTLA-4 therapy. So CTLA-4 therapy, the side effect we think of associated with this is hypophysitis. It can cause thyroid dysfunction, but it's less common. This is an example of a patient who developed endocrine disease following ipilimumab therapy. So he was 77 years of age, he'd had melanoma, he had metastases discovered a year ago, and so started on ipilimumab, and he became fatigued and dizzy. Sodium was low, cortisol was undetectable. And you can see that he has central hypothyroidism. He's got a low T4, low T3, and a TSH that has not risen as you would expect it to. He also has a low testosterone with inappropriately normal gonadotrophins, low prolactin, low IGF-1, and undetectable ACTH. So no doubt that this man has pan-hypopituitarism. So he had an MRI of his pituitary, which showed a mildly enlarged pituitary gland with no suprasellular extension. And this was in keeping with ipilimumab-induced hypophysitis. So patients who develop at this type of hypophysitis will often have endocrine dysfunction, and most commonly it will be multiple pituitary hormones that are affected. So TSH deficiency is very common, indeed the most commonly described anterior pituitary deficiency in this situation. ACTH deficiency, very common, and of course very relevant because we need to give steroids prior to starting the thyroxine. Gonadotrophin deficiency, common. Growth hormone and prolactin, not described as commonly as the others, but perhaps we just don't check for it as often. Patients will often present with a headache, fatigue, hyponatremia is common, anorexia, nausea, and visual field defects have not been described to my knowledge. Risk factors are male gender, higher dose of ipilimumab, and age over 60. And they should all have pituitary imaging performed because they may be unlucky and have a pituitary metastasis, or they may have pituitary adenoma. So these patients should have imaging of their pituitary. Most, but not all, will be abnormal. And it has been described that the changes of hypophysitis resolve in all patients, and that occurs over variable time. So it may be the case that you image your patient and they have a normal MRI pituitary, but it doesn't exclude the fact that they may have had hypophysitis and you might have just missed the changes on the imaging. The onset with CTLA-4 agents is on average 2 to 3 months, but there's a very wide range. And hypophysitis is described with PD-1 agents, but it's less common and appears a little bit later at 3 to 5 months. So the same paper that I discussed for PD-1 agents also provided a helpful algorithm for patients who are starting CTLA-4 therapy or combined CTLA-4 PD-1 blockade. So prior to therapy, baseline TSH T4, and I would do an 8 a.m. or 9 a.m. cortisol, but personally I don't check their ACTH because it's a little bit difficult to check it, and it doesn't really add much, I think, unless the cortisol does drop later on. At that stage, it's very helpful to check. So routine TSH T4 and a cortisol level at least monthly during the first 6 months, every 3 months after that for the next 6 months, and then every 6 to 12 months after that. And I would keep a degree, high degree of suspicion for hypophysitis later than this, because of course it can be very difficult to diagnose. And then in terms of treatment, then if you suspect a patient has hypopituitarism or hypophysitis, this might be based on their clinical presentation, the biochemistry that you have, or maybe even a report of an abnormal MRI. Draw blood for anterior pituitary hormones. I would do a clinical assessment for diabetes insipidus. DI is exceptionally rare, and it doesn't really happen with these agents, but if they're unlucky and they have a metastasis to the stalk, perhaps they might have DI, so it's worth just asking them questions about that. Visual fields to confrontation, and then start hydrocortisone replacement if their cortisol is not clearly within a normal range. Image their pituitary with an MRI, and I'd do a formal visual field if I was in any way worried about the chiasm. And high-dose steroids are usually not required, but you might use it if the pituitary was near or encroaching the chiasm, or if the patient had very severe headaches. And then, of course, we would replace their hormones appropriately, except for growth hormone, because these patients have active malignancy, continue the immune checkpoint inhibitor, and monitor their replacement every couple of months for 6 months, then every 3 months for 6 months, and then every 6 months. And I'd repeat their MRI pituitary if it was initially abnormal at about 3 months. So common questions for these patients: what should we do if hypophysitis is seen incidentally on MRI? And this happens not infrequently. So if you see that, I would just continue the immune checkpoint inhibitor, and I would do more frequent anterior pituitary hormone profiling, expecting to see that there most likely will be some hypopituitarism developing. Do we need to stop the immune checkpoint inhibitor therapy if hypophysitis develops? Almost always no. You may want to temporarily stop treatment to replace the hormones, of course, primarily hydrocortisone, but then you can restart. And I would stop if the pituitary is causing chiasmal compression, and again, liaise with colleagues about the risks and benefits of continuing. So these are my key messages for immune checkpoint inhibitor endocrinopathy, focusing on thyroid dysfunction. It's difficult to detect, so we need to screen for it. It's really important that we liaise with our oncology colleagues, and we also need to be available for phone advice. They're not used to managing patients with pituitary disease and thyroid disease, so they need our help. We should be there to give it to them. CTLA-4 agents, think about hypophysitis in 5 to 8%, with thyroid dysfunction in less than 5%. Thyroid dysfunction occurs very frequently with PD-1 agents, so that's 10 to 15%. And it's usually hypothyroidism, maybe thyroiditis, rarely hypophysitis. Following CTLA-4 therapy, always think about checking for adrenal insufficiency before starting thyroxine, and always image the pituitary in cases of hypopituitarism. You'll see endocrinopathy usually within 3 months, but it can occur later. So watch out for it at a later stage. And in most cases, the immune checkpoint inhibitor can continue, but you may need to hold it temporarily. And it's very rare that you need to use high-dose steroids. The good news for these patients is that their development of endocrine side effect may signal a good oncological response. And there have been some studies supporting that. So it can be nice to tell patients that. And I believe that studies accurately assessing the rates of endocrinopathy and recovery for the future are needed. And I thank you very much for your attention. And it was a pleasure to be able to give this talk for you today.
I think you're muted, Dr. Maki.
Am I muted? So all right, go again. I'm just thanking you, Dr. Carla, for this very elaborate and useful talk on a novel therapy. And we'll go for the audience if we have any question. I'm sure the panelists are all ready for questions. So see and check if there are questions around. Organizing committee, how can we get through to this? Questions? Okay. I'm not getting any questions on my email. I don't know.
Dr. McKean, sometimes they put the question on the chat.
I'm looking for that. I can't see anything. I can only see a message from Dr. Ali Zahrani thanking some people, but no questions. Shall we call it a day?
I think Dr. Al-Dasuki is wanting to ask, raising hand.
Okay, where is he?
Yeah,
Okay.
can I be heard? Can I be heard?
Yeah, go ahead, please.
Oh, yeah. Thank you, everybody. It's a pleasure. It's still morning here in Michigan. So very, very great conference. Just a quick question to Dr. Qaisi. So on the monoclonal antibodies, now that we have the triptonumab.
Yes, that's the one. It took me a while to know how to pronounce it.
Yeah, I know. I say the brand name Tepeza. It's much easier.
Yes, yes.
I don't know what they call it in Europe or over elsewhere.
I don't think we have it yet.
You guys don't have it?
No, I don't think we have it yet. It's more of research now. We have it, but it is quite expensive.
You know, we've had it since the beginning of the pandemic, and
yes.
It is like miracle. It dissolves everything behind the eyeballs. It's unbelievable. So anyway,
yes.
So then I just wanted to ask then if you may have then read about the science. And I've been involved extensively with that, both clinically and also in collaboration with Terry Smith and other colleagues at the University of Michigan Kellogg Center here in Ann Arbor. But what I didn't understand, and I still am not understanding, how come that like 8 infusions over several weeks will ensure a long-term sustainable remission? In other words, what would they do? I mean, would they turn off the whole Graves pathophysiology? Because I mean, the way I understand pharmacology in certain ways, at least, is that there are medications that, you know, as long as you take them, they act, and if you stop, they stop working, except for, I don't know, some other, whatever, maybe chemotherapies and things that like cell killers and whatnot. So in your opinion, or what would explain long-term remission? But I know that troposumab is still about 3 years in clinical practice, so probably we don't have long-term studies.
So Dr. Al-Dasuki, do you mean the 8 infusion? Do you mean for teprotumumab or for steroids?
No, teprotumumab.
For teprotumumab. Now remember what I explained in my.
They give 8 cycles.
Yes, it's over 6 months, isn't it? In the study.
Yeah, every 2 weeks you get one infusion every 2 weeks for a total of 8.
Yes. Now you can imagine the first time I spoke to our manager in the NHS about this medication, and I said to them that it could cost $300,000 American dollar. They had a heart attack when they had the price, especially when, you know, we in the NHS, we provide the best sort of care with the with least amount of money we could give. Now remember what I explained earlier with the active phase and the chronic fibrotic phase. So the whole idea, so even if you leave a person with a mild thyroid eye disease or moderate thyroid eye disease without any intervention, they will cross this phase and they will have long-term fibrotic phase. So all what we are after is trying to act as quick as in the active phase. Now, the question, what you are asking is there long-term sort of recurrence? That we've seen people who have thyroid eye disease who may have recurrences. It's not very common. It's so maybe like every year we have 1 or 2 people, but these people, some of them may have a very high TSH receptor antibody that sometimes is unrecordably high in the lab. So the whole idea of the treatment is just to cross the active phase. Once you cross the active phase, minimize the risk factor that is modifiable, like smoking, then hopefully the recurrence rates in the future could be less.
Thank you.
Okay. Any more questions? Dr. Ali Zahrani, please.
Yes.
I have a question for Dr. Ali Zahrani. Dr. Ali,
yes.
You have mentioned like a 70% of unindicated surgery sometimes, and you thought the added molecular genetics might have saved. But what about the cost? And the cost effectiveness of going for molecular genetics or surgery if you are suspicious?
Yeah, this is a real issue with this and with the drugs that was just mentioned by Dr. Ahmed. I think the real issue is really the cost of molecular testing. This is why it's not widely adopted in our region and even in Europe. Because again, the average cost for Firma or Thyroseq is anywhere between $2,500 to $4,000. And I think that's prohibitive to their widespread use. So yes, they are costly, no question. And hopefully with time, and now we have new tests coming into use, and hopefully with the competition and with the time, the cost will come down.
Good.
Dr. Ahmed?
Dr. Wiam, yes?
Marhaba, I'm covering for Khalid. Khalid had
Okay,
an emergency leave, so he told me to cover for him. Thank you
very
for all the speakers.
Thank you.
It's nice to see Dr. Ahmed face to face. I'm grateful for Dr. Ramzi Ajjan who gave us your contacts.
No problem.
Very nice lecture. I have two questions from the audience to Dr. Ahmed.
Yes.
The first question is about patients who come to us with Graves' disease and they have exceedingly high TRAb. Should
Yes.
we proceed with thyroidectomy?
So we do proceed with thyroidectomy because we found these patients, they have very bad thyroid eye disease in the future. And even if we go for a blocker replacement or block with carbimazole, the recurrence rate is humongous. So we proceed with thyroidectomy.
Okay. And there's another question about the use of several other drugs, sotagliflozin, selenium, H2 blockers, metformin. There were small reports about improvement in the eye. Have you seen anything in that?
So selenium, yes. Metformin, never used it before. What else? Sorry?
Sotagliflozin, the
never
SGLT2
used it.
inhibitor.
No, never used it before. But the selenium is a very proven study. And it doesn't have that much side effect and that much cost.
And the dose they use?
200 microgram once a day. The study was done for a year, but the major impact on the clinical activity score is 1.3 over 6 months. This is why we use it for 6 months.
Okay. Now, if you remember, there was a paper about increased incidence of diabetes with a dose of 200. Would you worry about that?
We do monitor these patients quite regularly. I mean, they come to the clinic every 2 months with a repeat blood test. I haven't seen anybody developing this yet.
Yeah. Okay, thank you.
Thank you.
Okay, any more comments? Yeah, Dr. Ahmed, again, for this funny drug, IGF-1 receptor inhibitor, does it inhibit the IGF-1 receptor or the complex with the TSH receptor? There is a complex that initiates the whole pathogenetic mechanism. Does it inhibit the whole complex?
It's the whole complex, yes.
Okay, okay.
Yes.
Any more comments, please? Otherwise, we may have to call it a day. Thank you very much for this very interesting talks and very, very novel therapies we have here on it. Thank you very much. And thanks to the organizing committee and to the audience for being here. And Dr. Wiam, thank you for joining us at the last minute. Thanks a lot. Thank you.
Thank you very much. Assalamu alaikum.
Bye.